Welcome to the Digital Planning Podcast. This series is designed to educate individuals about all things digital in connection with estate planning, business planning, and estate administration. To keep up with all things digital, please subscribe at iTunes, Stitcher, Google Play, or wherever you download your podcasts. And now, Jennifer Ziegel, a partner at Kleinbart LLC, Ross Bruck, a principal of Estate Genie, and Justin Brown, a partner at Pepper Hamilton LLP, with today's topic.
Welcome back to the Digital Planning Podcast. I'm your host, Jen, and I'm with my co-hosts, Justin and Ross, and we have a very special guest for you today. With us is Dr. Atul Gupta, who is the Global Chief Medical Officer and member of the management team for image-guided therapy at Philips. Dr. Gupta is an actively practicing interventional and diagnostic radiologist with over 20 years of clinical experience. Dr. Gupta's key responsibilities at Philips include supporting innovation and new product development in radiology, cardiology, vascular, surgical, neuro, and oncology interventions. Dr. Gupta has been repeatedly recognized in the media as a top physician, and he is a reviewer for several medical journals, and he has published and lectured internationally on the topics of augmented reality and 3D live image guidance, among other topics. Thank you, Dr. Gupta. Thank you so much for being here today.
Thank you, Jen.
What exactly is an interventional radiologist?
So it's a bit of a confusing term, so maybe let's rewind it back to the very beginning. Interventional radiology, quite simply, is modern-day surgery, but it's a very new specialty. It's only about 3 decades old, which is not an old specialty at all. So if you start from the beginning, surgery goes back thousands of years, and for almost all that time, surgery requires us to open up a patient, to see the organ, and then put a device to fix the organ. Now we have advanced imaging technology like X-ray and ultrasound and MRI where I can see inside a body without opening it up. So that's the imaging, and we talk about it as image-guided therapy. And so that's one part of the equation, is being able to see inside of you. But now we also have miniature devices, things like angioplasty balloons and laser catheters and wires, that we can guide through the body without opening you up. So if we couple the imaging to the therapy, that's image-guided therapy. And that's what interventional radiologists do. And we can fix things in your blood vessels and in your heart and in your brain and in your liver, all without any large scar, incisions not much bigger than a pencil point. And what that means is faster recovery. Patients can oftentimes go home the same day.
So there's a lot of technology involved in interventional radiology.
Yeah, I mean, it's very interesting being an interventional radiologist. People know what a cardiologist is. They treat the heart. And a neurologist, they treat the brain. But the name interventional radiology is a bit confusing because it, in fact, doesn't encompass one organ system. We kind of treat everything everywhere, and no 2 days are the same. So to give you an idea of my day, I could do 8 cases a day, and I could be treating a liver blockage in one patient and save a trauma patient from bleeding to death. Then I could kill a kidney tumor. Then I can remove a clot from somebody's brain to treat them from stroke. And then I can drain fluid from the lungs. And then I can repair a broken backbone, all in one day. And we can do this, again, through incisions not much bigger than a pencil point. And so we solve a lot of problems for other doctors. It lets us be not only technically very good, and we do heavily rely on technology, like you just said, Jen, but it also lets us be creative and collaborative. And it's no wonder that for the last 2 years, interventional radiology fellowships, the specialty training programs, is the most competitive specialty now in medicine, because everybody realizes it's really the future.
When you were in medical school, was this actively taught? Did you pick it up there, or was it something you learned through the course of your career as it evolved more recently?
Yeah, it's a good question, Ross. So actually, many people that are interventional radiologists started their career as surgeons, and in fact, I did as well. And I had been accepted to a surgical training program here in Philadelphia. I was training in New York, but the very last rotation I did in medical school, just 30 days before graduating, was interventional radiology. And then I was hooked. And so it was a brand new specialty at the time, and now it's very, very popular.
How did you become interested in the technology aspect of medicine?
I think all of us are probably around the same age, so we have a very interesting perspective because we have if you look at the consumer world with the technology, we all grew up in a time probably without cell phones when you were very, very young, and without PCs, and you used phone books, and you weren't always connected. And then we also get the perspective of seeing how fast that technology has entered our consumer lives. Similarly, in my field of interventional radiology, as I said, it was a very new specialty, so I've watched firsthand the digitalization of health take place. Interventional radiologists are very tech-savvy people. What brings you into the specialty, because we rely on technology. You can't do the things that we do without digital equipment and microscopic and miniaturized devices and digital health and data. So I think by nature of the specialty, it pulls in very tech-savvy, tech-interested people.
So within this field, what would you consider the most prominent technological evolution over medicine?
Well, I think, as I said, what I've seen firsthand over the last several decades is this concept of digitalization of health. So I'll give you an example. And Jennifer, I know you have family members that are in healthcare, radiologists, your father. You probably remember going into the hospital and seeing your father looking at x-rays and MRIs and CAT scans on physical films that were being hanged on a rotator, what we called rotator.
I absolutely do, and I have fond memories of my special teddy bear going into the imaging machines as well, which I'm sure would not happen today.
So in my lifetime, what started out as physical films that we put up on displays to look at had turned into what we call packs. So now we digitize images, and images are acquired digitally, and now that was one of the first digital revolutions. So we don't look at film anymore, we call it film, but we're really looking at it on banks of monitors. Then we also went from an era of having humans transcribe and type into computers what we're seeing to voice transcription. So then I would start talking into a computer, and the computer would immediately transcribe it. And I've also seen what went from physical charts to now electronic health records. And so we're seeing this digitalization of health take place very, very quickly. And that also includes things like electronic health records, telemedicine, artificial intelligence, AR. And so this whole technological evolution of digital health, I think, is probably the fastest moving space in my lifetime.
So Atul, you're still practicing, but you're also at Philips. So how did you decide to bring the two together and kind of change your career path and work in both areas?
It sounds like it's very different, but actually the vision that I have as a physician is exactly the same as what Philips has as a company, but just on very different scale. So the Philips vision, they strive to make the world healthier through innovation, through technology. And Philips actually has a very ambitious goal. We seek to improve the lives of 3 billion people a year by the year 2030. And if you crunch the numbers, we're already well on our way to achieving that. 2.1 billion patients per year on planet Earth are improved, have their lives improved, sometimes even saved by technologies that Philips creates. So it's very much in line with what doctors go into medicine for. I still get to practice several days per month, and so that lets me achieve my goal of helping people and saving lives and improving lives, not just directly, but also indirectly when I work with Philips, helping them deliver new technologies that are going to change how we all get taken care of in the next 5 to 10 years.
Probably helpful for Philips as well, because you also maintain that real-world experience and see what's going on the front lines while being able to contribute to Philips' mission or the vision that they have.
Yeah, I think that being able to provide real-life insights as to what's happening in the field is always very valuable. And of course, I'm not the only one. We engage with hundreds and thousands of physicians and nurses and technologists and administrators and patients throughout the world. But having somebody in-house be able to guide some of the roadmaps is very valuable.
So Atul, you started to touch on some of the trends that you're seeing in the medical field with technology. What else do you see, and can you go into a little bit more detail as to what trends you see in the medical field going forward?
Well, we're a technology company, but it's always important to remember that we don't see technology being the solution. It's the enabler. It's ultimately about figuring out what's the unmet need, what's the problem, and then making technology make that better, not pushing technology out there just for technology's sake. And so every solution that we create, and this is a big buzzword in all of medicine right now, is something that addresses what we call the quadruple aim. So that's a very hot topic right now. So in medicine, the quadruple aim is creating solutions that improve outcomes, because it's always about improving patient outcomes, but reducing cost, and also improving both the patient experience and the staff experience. Digitalization of health is a great thing, but if it's not implemented in the right way, which up till now I don't know that it has been, it can wreak havoc on the lives of not just patients but also physicians. There's a tremendous amount of staff dissatisfaction that you might be reading about right now in hospitals, largely because of things like electronic health records, which are basically weren't created with physicians in mind, and so they see this as a cumbersome process that they have to go through, not something they can use. So I think the big trend right now is to try to address the quadruple aim. And so it's interesting, being able to do all of this, doing more with less, reducing costs, everywhere I go, and I travel around the world a lot, it's a common theme in almost every country. So I was in Japan a few months ago, and I met with the Ministry of Economy, Trade, and Industry. And in Japan, as you probably already know, they're suffering with this problem of an aging population. People are getting older and older in Japan, and of course that means they have a lot more chronic disease. But on the same front, nobody's having children in Japan, so they don't have people to take care of the older population. They also don't have the tax base to pay for all of that medical care. So they're struggling to figure out how can we do that. And that's where digital health and technology can fit in. If we can create solutions that make image-guided therapy, procedures that were once a week in the hospital, only a few hours in the hospital, and then you can get out of the hospital quick. If we can figure out ways to use digitalization to treat you at home with telemedicine, it's those types of solutions that countries are looking for. And what I see in Japan, I also see in Thailand and in China and in Australia and certainly in the US.
So what is the methodology, that you and Philips utilize to figure out what tech trends, are going to turn into real solutions?
So we're somewhat fortunate because we have a global footprint. So we have a nice Rolodex of very smart people that we can rely on. We have 70,000 employees in over 100 countries. And so what we do is we do this process of co-creation. So Philips is a huge design team. It's a design company actually at heart, an innovation and design company. And so we bring people together in co-creation rooms, and that's all the stakeholders. So patients and doctors and Philips engineers and scientists and hospital administrators and anybody that's suffering with a particular problem that they're trying to solve in a hospital. Maybe it's how do we reduce cost when we put in aortic valves? Is there a way to, use digital pathology data better? And using this design process, this co-create session, we try to come up and prioritize how we tackle these problems. I really believe that collaboration leads to the best innovation. It's not just pushing technology out. And that also means, by the way, collaboration even between other companies that are sometimes thought of as competitors. In healthcare, time is of the essence, so none of us can do it alone. So that is why, for instance, we at Philips collaborate with Microsoft, and we announced a very large partnership earlier this year to co-develop an augmented reality solution for operating rooms and image-guided therapy. Two very different companies coming together to try to solve a problem in healthcare. Collaboration is really important. There's something else that's very interesting that we do. Everything that we design is probably going to take 5 or 10 years to come out. So in some way, we also have to capture what the teenagers are thinking, because they're going to be our doctors in 10, 15, 20 years. So we do all sorts of interesting things like bringing teenagers into operating rooms and having them play with our equipment. And you get a very interesting perspective when you talk to 12-year-olds who, by the way, were born in 2007, the year the iPhone was invented, right? So they don't know anything but touching and voice recognition and voice control. And so you get a lot of insights when you talk to teenagers and have them play. And they bring things to the forefront, like, why are we doing it this way? Because we're so used to doing things a certain way, we sometimes need that kid's input to tell us. So we do things like that as well.
You just mentioned AI. So what is your experience with that?
There's a tremendous amount of hype if you pay attention to anything in the news about AI, artificial intelligence, or augmented intelligence, and a lot of it is just that, it's hype, and you have to be very careful because people are starting to look at AI with a bit of skepticism because people have been talking about it for a long time. So concrete examples of what AI means in our life today, actually, in healthcare. Well, first of all, I don't think we're going to be living in an era, at least in our lifetime, where robots are going to be running around with stethoscopes taking care of us. AI is not going to replace doctors. But I do believe that doctors that use AI will replace doctors that don't. Just like doctors that use PACS and telemedicine and voice transcription, the trends I talked about from 10 or 15 years ago, Jen. That's just part of the common way of doing medicine now. AI is the same way. So I'll give you just 3 simple tasks that we do now that AI is helping us solve. If you're a cancer patient and you get a CAT scan, it used to be that CAT scans 20 years ago were just 40 slices. That exact same CAT scan now is 1,000 slices, and I have even less time to look at that and to look at the tumors and find the tumors and then measure the tumors. Well, if we can embed AI into this process, I can find the tumor, but the computer can do the measuring for me, the monotonous task, and that can save time. So that's one of the solutions that we have. Automatic measurements, that's kind of a personal assistant for me. Stroke, as you may know, we have a saying, time is brain. When you have a stroke, you actually lose 2 million neurons in your brain every minute that your brain is not getting blood. So it's my job, it's our job as society to get that clot out of the brain to save your brain. Time is brain. So where are the bottlenecks? Well, one of the bottlenecks is the first thing that happens is you get a CAT scan of your head in the hospital. And then that CAT scan sits waiting for somebody to read it to make the diagnosis of a stroke. And that process could take 10, 15, 20 minutes. We now have solutions where artificial intelligence, while you're on the table, can be an early warning system. And it can automatically say, you know what, I think there's a stroke here, and put it to the very top of the list so a radiologist looks at it right away, shaving off 10 or 15 minutes, which is 30 million neurons. So that's a very tangible way AI is being used. And maybe one more I'll talk about, it goes to wearables, and I think maybe we should talk about that a little bit later as well. But even wearables are making use of AI to improve our life. So we have a solution called IntelliView Guardian. It's basically an early warning system. It's a wearable for the hospital. So it's a patch that we put on patients in a hospital, and it's tracking all sorts of vital signs, your heart rate, your temperature, your respiratory rate, your blood pressure, and so on. And we can put all of this stuff into a computer, and the computer can detect, before humans can, who's at risk of decompensating. Because right now, nurses check your vital signs every 15 minutes, every 30 minutes. If it's doing it every single second, maybe we can see trends before humans can. So they did a study. They looked at 2,000 patients with this early warning system, and they found that they decreased the amount of cardiopulmonary arrest in a hospital by 85%. They reduced the death rate in a hospital by 20% with people that were wearing these early warning system AI patches. So these are some very tangible ways in which AI is already improving our lives, whether we realize it or not.
How widely used are some of these AI methodologies?
It's moving so fast, this space. So what I just described to you is a solution that's only been out for the last year or two. So I think that it's not being used as much as it should be, but it is going to move very, very fast now.
And what are some of the hurdles to implementing this technology?
Well, I think that for AI specifically, people are struggling with how do you train the engines? How do you get all of that data, the data lake, to train the computers, the machine learning, to recognize, for instance, a stroke or your blood pressure is dropping? That requires a large amount of anonymized data. Hospitals, health systems, patients, countries need to figure out the regulatory process to make that ethically and legally available to somebody, somewhere, so that they can train these computers to do all this incredible stuff. And that's what people are struggling with now. Some countries are doing it very quickly. Countries like China and Thailand, they're moving very quickly in the AI space. Other countries are struggling to how do you balance the appropriate cybersecurity and patient privacy, but still try to get some of the solution to save lives.
As much as Philips is helping to lead the discussion and be at the forefront of advanced technology, you're also dependent upon other advancements in technology. I can't see a 5G commercial from a cell phone provider without seeing medical imaging as part of that. Hey, we're going to be able to share this data quickly and more easily than any time in the past. That must be true for everything you're talking about here, that as much as you're working on this, it's dependent upon others' work as well?
Yeah, I mean, you need to have the infrastructure to support For instance, sharing of your health data when you go from one hospital to the next, or if you go from one doctor to another, or maybe you're going from one state to another. And right now, that's kind of an issue that we have, at least in the United States, where we call it interoperability. Hospitals and health systems are acquiring all of this electronic medical data, and they're even sharing it, if they want to, with the patient themselves. But how do we make it so that I, as a physician, can share it with another physician that's out of that hospital if you want to transfer your care? And so I and many physicians are confronted with this problem in the United States all the time. And I hate to tell you what the solution is. I mean, I don't know if you know what the solution is if you come into a different hospital. You can probably imagine what we do is we have to repeat a CAT scan or repeat the blood work because I can't get access to the stuff that you had done elsewhere. And this, of course, raises the cost of care. And so interoperability is absolutely key.
Is there resistance to interoperability?
I think in the United States, and this is just my personal opinion, I think that a lot of hospitals are a bit resistant to this because if you think about it, hospitals may not be in their best interest to have you be able to leave that hospital or that health system to go to a different one. So if you have all of that data and only they can keep that data there, it's just one extra hurdle for you to leave that health system. So hospitals are a bit resistant to allowing interoperability. It's bizarre because the technology exists. It's just a uniform standard of sharing data, and other countries do it. And I'm sure that we will in the United States, but there is a bit of resistance. In a way, it's almost like holding a patient hostage by holding that data.
It's difficult for the common patient to understand who cares about this and who doesn't, and what a hospital's views are there before they seek treatment.
But you raise an interesting point, because maybe as people are becoming much more savvy about things like digital health, it's an opportunity for health systems to promote the fact that we are an interoperable health system. And maybe, particularly the younger generation, will seek out places that are much more favorable in sharing their health data.
I agree, and I think it could be a marketing tool for hospital systems to utilize going forward, that they incorporate interoperability into their practice, and the dissemination of medical records is a lot more flexible and not siloed as it is in a lot of hospitals and practice groups.
Yeah, I mean, as of today, about 80% of physicians share a patient's health data within their own hospital system, but only 1/3 of physicians today are able to share it outside of their own facility. I think one of the biggest reasons is, of course, they don't have a physical way to do it, but also I think there are also concerns about things like cybersecurity and HIPAA and privacy and so on. So a lot to figure out.
And I'm sure as the technology develops, there'll be different vehicles that are going to be utilized to accomplish cybersecurity issues, HIPAA, privacy considerations, as well as transferability of medical records, particularly with utilizing permissioned blockchains in the future for the storage of medical records and information.
Thank you for listening to this episode of the Digital Planning Podcast. In our next episode, we will continue our discussion with Dr. Gupta.
Thank you for listening to this episode of the Digital Planning Podcast, the podcast designed to educate individuals about all things digital in connection with estate planning, business planning, and estate administration. Please subscribe to this podcast and leave us a rating or review at iTunes, Stitcher, Google Play, or wherever you download your podcasts. Thanks for joining us. We'll see you next time.